Good evening, ladies and gentlemen. This is Dr. Dhruba Bhattacharyya on this side. Today, this video has got a definite purpose. We have decided to have a short discussion regarding a very common topic called heart attack. Popularly known as heart attack, to our medical terms, it is known as acute coronary syndrome. There are three elements over there. One is unstable angina, one is non-ST segment elevation MI, and another is ST segment elevation MI. So heart attack at the first point gives once we hear the term heart attack, it gives a lot of panic to the patient relatives, and it sends chills across the spine that the patient has got or the subject has got heart attack. So nowadays we often come across the diagnosis that this patient has got ischemic heart disease, this patient has got hypertensive heart disease, this patient has got dyslipidemia. These terms are very common these days, and in the era of smartwatch, everyone is monitoring their steps and all every day, how much workout they are doing, how much calories they are spending. But despite everything, our lifestyle has changed like anything. Pre-COVID and post-COVID, the things have been upside down, and every day as physicians, as cardiologists, we are encountering younger patients with heart disease. So in the pre-COVID era, we used to get patients mostly with atherosclerotic heart disease. Post-COVID era, inflammatory component has gone up in a terrible way. And we are encountering patients every day to our clinic practice, to our cath lab services, who are aged between 30 and 40. So, in simpler terms, that what happens when there is a heart attack? And can we have some symptoms earlier? Do we usually overlook the symptoms? These are the most important things which we must address in this video. So, heart attack in the simple terms is that when a supplying vessel which supplies the heart itself gets obstructed to a critical level, that it is not getting adequate supply and there is a permanent muscular damage. This is called heart attack. The major arteries in the heart, like left main coronary artery, the left anterior descending artery, the obtuse marginal arteries, the circumflex arteries, these are the right coronary arteries. These arteries are the vital arteries which supplies the heart as a whole. And once these get obstructed, then there can be an acute and abrupt cutoff of the supply of blood. It causes heart attack. So, does the menacing diagnosis doesn't give any premonition? Definitely it does. It is us that we ignore, and we always bypass those signs and symptoms which the body usually gives. Many of the patients, they do come up with a history of fatigue. So fatigue is one of the commonest symptoms in which it signifies that there is a lack of blood supply within the cardiac musculature. So there is an entity called heart failure. So what does the term heart failure mean? The heart failure means there is inadequate pumping of the heart in order to supply the whole body system. As the heart is failing to pump adequate blood, it is not able to supply the whole of the system. Hence, there is an entity called heart failure. There is systolic heart failure, there is diastolic heart failure, and these days there has been a very lucid classification which has come up: heart failure with reduced ejection fraction, heart failure with preserved ejection fraction, and there is an entity as well where there is heart failure with raised ejection fraction. So, coming back to the primary entity heart attack, how do we diagnose heart attack? Once the patient is coming with a classical symptom of crushing central chest pain with sweating, with pain radiating to the left jaw, to the left upper limbs, and there is fall in the blood pressure, definitely the high index of suspicion that should be that we are encountering a case of heart attack. What is the difference between unstable angina and a heart attack? Unstable angina, at certain point of time, with the introduction or with the usage of the nitroglycerins or the anti-anginals, it will respond to some extent. But when we encounter that the symptoms or the signs are not responding to the standard anti-anginal which has been administered immediately, you should have a high index of suspicion that this subject must have got a heart attack. So once we encounter heart attack that we have discussed already, the classic signs and symptoms, we should immediately, as quickly as possible, whatever may be the location of yours, we should immediately load the patient with three popular agents. One is aspirin, one is clopidogrel, and high dose of statin. This is available at every nook and corner of the city. Each and every person should have a basic idea that give 300 milligram of aspirin, 150 milligram to 300 milligram of clopidogrel, and an 80 milligram of statin, so that you can buy time for the patient to at least he or she can reach the nearest hospital so that he can have an assessment or a primary angioplasty. This is pretty important. Until and unless the patient lands up in a massive cardiac attack leading to a cardiac arrest or to a cardiogenic shock, most of the patients can be salvaged. The only thing is that we lose the golden hour. We run from here to there thinking that this is not a heart attack or this is something else. This may be a gastrointestinal phenomenon. Many of the middle-aged and elderly people, they have lost their lives, and mostly it happens between 11 p.m. and 4 p.m. when the people come to a conclusion that this is not heart attack, this is gas, and we have lost patients in the fraction of seconds or maybe within hours. We have lost the patient who would have been saved if would have been loaded in time and taken to the nearest cardiac facility in our hospital. So once the patient reaches the hospital, in a patient of heart attack, we have got very advanced and very good treatment these days. If the patient is in a hemodynamically stable state, which means the BP is normal, the pulse is more or less palpable, take immediately, the patient is already loaded with aspirin, clopidogrel and statin. The patient is usually taken to the cath lab, angiogram is being done until and unless there is any obvious contraindication. If the patient is subjected to primary angioplasty, there is immediate reversal of the cardiac damage what has happened. The amount of muscle damage actually defines how much recovery is going to happen, what will be the mortality over the next 30 days, which is pretty important. Now, the next phase is that once we encounter with the heart attack and a primary and an angiography is done, we could decipher that how much blockage is there and how many arteries are blocked. If it is more than 3 vessels, usually the scope of angioplasty is limited. Then we land up into the coronary artery bypass surgery. And post to angioplasty or post to coronary artery bypass surgery, the adequate blood thinning by the antiplatelets, which is usually dual antiplatelet therapy, is of pivotal importance, and a bare minimum of 1 year DAP, dual antiplatelet therapy, has been recommended, and a periodic checkup of the heart, that how it is behaving after 3 months, after 6 months, after 9 months, after 1 year, and how much there is improvement in the ejection fraction. We should assess by serial echocardiogram and by the serial ECG. The risk factor modification is pretty important. We have still now discussed with the advanced and the basic treatment of heart attack. The risk factors which are modifiable, we can reduce the body weight, we can improve our diet, we can moderate our alcohol intake, we can stop the smoking entity, so that if we can cut down with the modifiable risk factors, definitely the longevity, the survival improves. And it has been recommended that taking the dual antiplatelets and statin in a proper way definitely improves the cardiac health in the long run, and many other good molecules, anti-heart failure molecules, many other new anti-diabetic molecules has been recommended by the American College of Cardiology, the Indian College of Cardiology. They have jointly recommended that these are the medications which can save life, which can prevent the remodeling of the left ventricle, and it also prevents from a future attack, from a next heart attack. If we see that the culprit vessel is more than 70% obstructed, it is wise to get it stented. There may be many other surrounding vessels which are obstructed by maybe 20-30%. We can adequately manage them with optimal medical therapy. But a check angio or a check follow-up by an echocardiogram or a stress thallium or a dobutamine stress echo is recommended at least every 1 year post to massive MI. The lifestyle modification post to myocardial infarction is of utmost importance. The regulated exercise pattern, the regulated sleep pattern, and you need to take care all the medical comorbidities which has possibly contributed to this massive event. Need to control the diabetes strictly, need to control hypertension strictly, need to control obesity, need to control OSA if someone is having obstructive sleep apnea, which is a very important modifiable risk factor these days. Most of the patients have central obesity in India and they are snoring loudly. So picking up of patients who has got OSA can prevent, if we can prevent OSA, we can prevent a lot of heart attack. Our regulated exercise schedule, our regulated intake on the and the moderation of the alcohol, complete stoppage of smoking will definitely help us to live longer, a healthy and a fruitful life. So once we encounter anyone who is having a heart attack, the immediate diagnosis, the immediate treatment and the long-term follow-up care, these three panels, these three segments are extremely important, and the modification of the lifestyle, it gives an enormous change in the cardiac musculature, and it also depends on the mood and of the patient, and accordingly we have to design the medical therapy as per the cardiac status, which should be regularly followed up in a cardiology or in a physician's clinic by a routine echocardiography every 3 to 6 months, so that we can educate and tell our patients that what is the improvement which has happened since he got the attack, what is the cardiac status at this point of time, how much improvement he has got, what is the pumping function of the heart of that patient who suffered a heart attack maybe around 6 months back. So these things need to be addressed adequately, and the patients must be aware that when to visit the cardiologist if he has got symptoms. That one angioplasty or two angioplasties doesn't ensure that he is not going to get another event in future. So being in touch with the proper system of cardiology, you need to follow up with your cardiologist so that you can prevent another episode of heart attack, and we should have a close monitoring of all the necessary blood parameters, namely lipid profile, creatinine, urinary albumin creatinine ratio, inflammatory markers, and with a special note, we have seen many a cardiac death which has happened after COVID. It was premature clotting of the blood within the vessels, and the use of anticoagulants, antiplatelets, they have gone to an enormous level after the COVID pandemic, and we have lost many patients posthumously. When autopsy were conducted, it has been found that there has been many instances that the patient has got pulmonary embolism, patient has got severe coronary artery disease, which was non-apparent to pre-COVID. So, when we are dealing with a subject like myocardial infarction, popularly known as heart attack, we should be pretty cautious regarding the quick diagnosis, regarding the early management, so that we can save life, because cardiac attack doesn't give you much time. You have to decide and take the decision of the treatment immediately. Within a flash of a second, we have to decide. Otherwise, if we lose the golden opportunity, we may not keep our patients alive. And many a times, reaching late to the hospital, even after the best of the treatment being offered, unfortunately, our patient doesn't make a good recovery, and the 1 month and 1 year mortality doesn't change much. They usually die out of heart failure. They have a poor pumping function, permanent cardiac muscular damage, and unfortunately, they lose their job, they lose their physical ability, and they die prematurely because of poor pumping function of the heart. So, keeping things to be pretty basic, today my take-home message is that do not underestimate even the minimal symptoms like fatigue, mild chest discomfort, breathlessness while climbing upstairs. Do not underestimate these symptoms. This may be a very early sign from your heart that it is not keeping a very good health. So please keep in mind, do not underestimate the cardiac symptoms. Please consult your doctor, please consult your cardiologist. Be safe. And with a special note, the winter months, these are the vulnerable time of the year in which the number of heart attacks and stroke go up disproportionately high. It has got disproportionately high. And the time between November and February, these vascular events, they are typically on a high. We have good armamentarium to prevent. Please help yourself so that your doctor can provide the best treatment to you when you are in trouble. Thank you so much. Thanks for appreciating.